It is our pleasure to have Dr. Pramod Prabhakaran sir with us as our moderator for the panel. May I now take this opportunity to request sir to please introduce himself.
Good afternoon, everyone. It's a real privilege to be here with the team at Somaiya and esteemed colleagues on the panel. My name is Pramod. I'm from Ghatkopar, so I'm a local person to Somaiya. I've been in the UK for the last 25 years. I'm a practicing clinician and hold a number of roles, including working as a faculty member at the National Association of Primary Care and at Imperial College. I've been a board member at Somaiya for the healthcare management program since its inception, and pre-COVID had the fortune to visit and teach students face-to-face and interact. So I look forward to a good engaging discussion, and I'll pass on to colleagues. Shall I direct it, maybe?
Yes, sir, you might.
Yeah, I'll ask Dr. Varsha Phadke to introduce herself. That's okay.
Very good afternoon, everybody, and welcome to this panel discussion. I am Dr. Varsha Phadke. I am the Dean of KJ Somaiya Medical College and Hospital. We are one of the hospital which was in forefront for management of the COVID pandemic since 2020. And we have managed more than 5,000 COVID patients. Now also there are a few patients admitted in this third wave. But fortunately, the number of admissions now have become less, and so also the mortality, which is less. Similarly, last year, when the vaccination program was rolled out in India, we have started the vaccination center also. And in various phases, we have included various age groups. And now we have also started giving the precaution dose. So I'm very happy, and thank you for including me in this panel.
Well, thank you so much, ma'am. It's a pleasure to have you with us today. Now, may I request Dr. Nav Chana to please introduce himself.
Good afternoon, everybody, and thank you very much for inviting me to be part of the panel and to have the opportunity of meeting you all. It's an absolute pleasure for me as well. So I'm a primary care physician, or as in the UK, general medical practitioner, and have a large and very busy practice in southwest London. And I've been a primary care doctor there for 30 years, just completed. I'm also a non-executive director of a hospital in southwest London called Kingston University Hospital, and have, like Pramod, been associated with the National Association of Primary Care. I was the chair of the organisation, and I'm now the medical director, and I've occupied a number of national and regional roles over the years, and pleasure to share any insights I might have with you and to think them through with you. So thank you for inviting me to join this discussion.
Thank you so much, sir. Now I would like to request Mr. Hanif Wazir to please introduce himself. So.
Good afternoon, everyone. Just likewise, as Dr. Nav Chana just mentioned, I'd like to also say thank you very much for inviting me to the panel. It's a real honor and privilege to be here. I feel I should be in the audience listening to all the fantastic students are saying and doing and learning from yourselves. My background is in healthcare. I've been working in the NHS and other healthcare institutions worldwide for about 25 years. So I started in operational management within hospitals, running various services like A&E, intensive care, what have you, operating theatres and so forth. And then I ended up in government policy institutions running services. Sorry, there seems to be some background noise there. Running some policy level projects around the introduction of private sector into the NHS, the introduction of things like PROMs, which is patient reported outcome measures, also looking at structural responses to bigger challenges that we face within the United Kingdom. I've also had the honour and privilege of working within the British government, representing the UK government to China, to the Middle East and various other places. At the moment, I'm working with a private sector company, which is called Inhealth, and they provide diagnostics to the United Kingdom NHS and other healthcare institutions. Thank you.
Well, thank you so much, sir. We're really elated to have you with us today. Now, I may kindly request Hendrikje Huysmans, ma'am, to please go ahead with her introduction.
Good afternoon from a grey and rainy Belgium. Thank you so much for inviting me to join this interesting panel discussion. My name is Hendrikje Huysmans. I used to work at the University College Leuven, Limburg, but now I work at the First Line Council of Leuven. And for the moment, I am the HR manager of the medical staff from the Vaccination Center and the program manager for the vaccination campaign in the city of Leuven. Leuven is one of the smaller cities in Belgium, but it's a big university city. So we have a very diverse population in our city and a very diverse approach to the vaccination campaign.
Well, thank you so much, ma'am. Thank you to all the panelists for taking out your precious time to do this today with us. It's a matter of pleasure for us to have you all with us. And now I may request Dr. Pramod Prabhakaran sir to lead us through the panel.
Thank you very much. When we got invited to this discussion, I mean, where do we start? I mean, COVID is such a complex, it has been once in a generation, once in maybe 10 generations in terms of its impact, and hopefully there won't be that many more. But how do we look at what's happened over the last 2 years? Today we have among our panelists people who can describe their experience, their real experience from different perspectives within the health and care system in different countries. And we would try to explore and get the insights so we can plan for the future and what does the road to recovery really look like. So obviously we'll focus on the vaccination part of it, but also the non-vaccination part of it. And I'll invite panelists to come in. I'll direct some questions, but feel free to engage in and keep it as informal and as lively as possible. If I may start with the look back, if you like, from today when we look back, it's 2 years ago, it seems like a lifetime ago. But to try and relive some of those experiences from different perspectives would be useful. And I might invite Hanif, Wazir to give a perspective on when, what was happening at the beginning and what the response was. Hanif, if you don't mind.
Yes, sure, no problem at all. If I cast our minds back, collective minds back to say around January 2020, I think that would be about right. December 2019, January 2020, February 2020 as well. There was an understanding that there was something going on globally, if I can say that. There was news coming out from China about a very infectious disease. Nobody quite knew what it was. People were talking about SARS again, people talking about respiratory diseases, people talking about influenza as well, a very highly contagious flu period. I was actually in India at the time myself. I was traveling through, I was in Bangalore around February 2020, and I was called back by the UK government to say, I think you might need to come back. There's something going on. So we need to be setting up and looking at how to deal with this from a emergency response perspective. Okay, sorry, let me just get that. Okay, so I remember flying back on one of the last flights out of India, thinking this seems a bit more serious than what people had anticipated. Of course, I was following the news for myself. And I'd actually been to Wuhan a couple of years back because that's where the latest British consulate had opened. So I had an understanding of the nature of the city itself, that most people were talking about in abstract terms, about a city that somehow originated a disease through something called a wet market. So it was interesting to see the kind of different levels of reporting going on. And then when I returned back to the United Kingdom, I went straight back into the Department of Health and Social Care, which is our equivalent to the Ministry of Health. And immediately there was a operations room set up, and ministers were involved from several departments across the government, including the Home Office, for example, Department of Health, of course. There's a security part of our government as well that was involved. Number 10, which is essentially the Prime Minister's office, and various others. And it all became very serious very quickly as to the impact that this could have within the British economy, how fast this disease was spreading globally, but also the acuity of the disease in terms of how severe it was when people were being infected and they were ending up in hospital, and how very quickly intensive care units were being filled up with people requiring ventilation, forced ventilation, as it were. And it started to dawn upon people that this isn't something that's going to be dealt with within maybe a month or 2 months with a rapid, focused response. This looked like it was going to be spreading, not just in the UK, but also globally. So there was a big discussion within government, I remember, around what our response ought to be, how serious this is going to be, how much money will it take, and so forth, and what level of expertise will we need to deal with this. And if I may just remind all the people on this call, this was all happening before any conversation was happening around a vaccination. So there's this whole phase around pre-vaccination response to a pandemic, which was all the trajectory was like vertical in terms of where we were going on this. So I have to say, it was complete chaos and panic within government in terms of dealing with this. There was no kind of, you may, when you do your MBA or master's dissertations in various management responses to things, you have this kind of view that there would be this very ordered structural response with lots of people very serious, sitting down around the table thinking about how we're going to do it. It wasn't anything like that at all. It was just pure chaos, panic, everybody just running around in the room, about 100 people, I would say, saying, who's going to give us the advice on this? Who are the experts? What are the responses from a government perspective? What ought to we do? Should we be closing down businesses? Should we be closing down travel? Should we be looking at protecting hospitals, protecting care homes, protecting parts of the population? So there was this whole kind of discussion going on, and nobody knew the answer. There were people who purported to know the answer, but genuinely nobody knew what the answer was. And that's what I think people were really frightened about. So that kind of just giving you a bit of the context as to where we were around February, and then March, April, it began to form. We formed a unit within the department called the NHS Test, Trace and Contain. You don't hear really much about the contain part, but the signal went out to the universities within the UK and abroad in the life sciences sector as well, to try to develop rapid testing technologies. Now it's so obvious and it's ubiquitous, it's everywhere. We have this LFT test, but at the time we were thinking, how are we going to test millions of people on a daily basis to understand the nature and progression of the disease? And tests were, this thing just didn't exist. So people were thinking everybody will have to go through the hospitals, or we'll have to go through primary care, or what does this test look like? Will it have to be a pinprick, for blood? Will it be saliva? Will it be urine? There was all these different types of discussions going on. And at the same time, people were being tasked in laboratories in the United Kingdom, particularly our government laboratories, to try to come up with a very rapid saliva test that could be very accurate, or as accurate as possible. 60% was good enough, I have to say, at this point. Any kind of test at 60% would have been deemed successful. Money was not an issue. Our budget in the end for test and trace department was 34 billion pounds sterling. So that's a significant budget given to this. So it wasn't a question of money, it was a question of trying to find a solution. There was a contain part of the department, which I think was largely around 2 postcode areas. So we have a postcode system in the United Kingdom, and it was deemed that we must control virus or outbreaks of virus or variants of the virus within 2 postcodes before we lose control, and so forth. So there was a whole team set up to do that, understand the nature of how to contain diseases. And we do have a public health function, protection function within the United Kingdom. That kind of almost was ignored, which was a massive error in terms of judgment. But we were also doing things like testing wastewater, sewage water, in various places to try to understand and ascertain the levels of infections across the UK. Then there was the trace part of it, which was thousands and thousands of people sitting at home on a phone call, tracing contacts for people who had tested positive to try to understand the spread. And then there was the test part, which I've been described already. So that kind of takes us to about April, May, I think. And largely the deaths were rising significantly, particularly across in Europe at the time. There was a lot of news about what was going on in Italy, of course, China. And that's just led to inevitably more panic. And then we were in lockdown where we weren't even allowed to stop walking. If we went out for a walk, we weren't allowed to stop walking. It was that level of seriousness, and you could only go out as an individual. So that's, I think, gives us a background as to where we were before conversations on vaccines started.
Thank you, Hanif. I'll just ask Dr. Varsha Phadke, because we're looking at almost the pre-vaccine period briefly, and then we'll move on to the vaccination and the post-vaccination world. But what was the early sort of experience in Bombay, in Maharashtra?
Yeah. So as mentioned by the earlier panelists, I think initially the situation was similar everywhere because nobody knew about this disease and it was something very new. So the government also and all the doctors and all the healthcare workers, it was a challenge for all of us to face. And so many new things, guidelines kept on coming. Then we had a task force which was formed to make the guidelines, and new guidelines kept coming all the way. So initially in April, when we had our first patient here, so that was the time when we started not only with patient management, but we had to do many things in the infrastructure and equipment wise also. Like we had to equip our ICUs more, oxygen supply. So all that had to be done on a war footing. At the same time, so that was one thing, was about patient management. Second was we had to take care of our healthcare workers. So we had to see that we give them enough protection, the PPE kits and everything that is required. Also make arrangements for accommodation and various other things also we had to look at. The first pandemic, there were a lot of casualties all over. So the various new medicines were also discovered. And then when we started giving, we did see an improvement in the later part. I would also like to mention here that a lot of donors came forward, and because it is important in a country like India, where the donors came forward and donated us a lot of equipments like especially the ventilators, BiPAP and all those things. So that was really a very helpful thing. Then we almost thought that the first wave is over, but after a few months we got the second one, which was a bad one because that time we had very, very severe patients coming. That is last year in April and May. That was the thing. But fortunately, it got over soon. And now the what we have at present are very mild patients, probably because of the good vaccine coverage. Yeah. So that is what I would say in short.
Yeah.
So that we
Thank
can
you.
move
Thank
on.
you.
Yeah.
Hendrikje, if I may ask you just very quickly on to the sort of initial period, what was the experience in Belgium?
We had like a same kind of experience as in the UK, but we were looking at UK and the Scandinavian countries, what they were doing. So we almost copied what they were doing. But in Belgium, the chaos was complete because we are a very small country. We have 11.5 million inhabitants, and we have 7 different governments. So we have a federal government, 3 regional governments, and 3 community governments. So we have like 7 ministers of healthcare in our small country. So you can imagine it was a big chaos because every minister wanted to have his say in the approach of the contact tracing, of the testing, of the reorganization of the healthcare. So it really slowed down the process for us sometimes, and it gave a lot of frustration for the people who were working on the field, but also for the community security for our inhabitants. It was sometimes very unclear what were the rules, and they were different in different regions. So it gave a lot of extra problems for us on the field to manage. I think the panic started when the pandemic broke out in Italy. Then we realized that it wasn't going to be a picnic, and that we had to, we had to start approaching the pandemic in Belgium as well. The contact tracing didn't work at the beginning. It was very chaotic. You had a contact tracing on the national level, but you also had on local level contact tracing. So sometimes people were called by 3 different services when they were infected. So that wasn't working very well. But we learned from other countries. We learned from our experiences. And now we are facing our 5th wave, the Omicron wave in Belgium. It's not under control yet. It even hasn't plateaued yet in Belgium. We hope it will plateau in the next weeks. But now we have learned a lot, but we are still learning every day.
Absolutely, absolutely. And not all of it was, there was a lot of complexity and obviously chaos and panic. But there was also a lot of innovation, even in the pre-vaccine period, for example, frontline healthcare. Dr. Nav Chana, and I'll revert to first names in a minute, but could you give a sense of how the health system responded innovatively in that early period?
Yes, Pramod, and I just wanted to just give a couple of examples of how it affected me and some of our frontline clinicians in that first phase. So I remember being at a national policy conference on the 27th of February 2020, and on the agenda there was nothing about coronavirus or anything of that nature. So it's just the routine, usual, business as usual topics. But the thing that struck me at this conference were the number of journalists that appeared from nowhere, from the Times, BBC News, ITV News, Sky News. And it sounded like something in the conference had no idea the significance of coronavirus at the time. And almost a lot of the conversations just seemed to be a little bit anecdotal rather than anything actually serious. So that was the first staging point for me. On March the 11th, in my practice, we heard of a young gentleman with sickle cell disease phoning up with a fever and a cough, and not feeling very well. At the time, none of us quite knew what was going on, other than maybe some sort of viral thing. He was given the standard advice that we would have given at that time. 12 hours later, he had died from an overwhelming infection that no one quite knew what. So for us, represented that something quite significant was happening. So that was March the 11th, and then March the 23rd. The UK government announced its first national lockdown, but between February the 27th and March the 23rd, nobody in my local medical community had any idea what was going on. It was absolutely unclear the impact of this thing. We've already mentioned the issues with PPE, supply issues and who was getting it and who wasn't getting it and what you had to wear. So as a frontline clinician, people were wearing anything from full kind of protective headgear with the full kind of infection control stuff to just maybe not even a mask, but possibly some gloves. Because nobody knew what the standards were, nobody knew what was required. We didn't know what we were dealing with. And ambulance response times in that period from February 27 to March 12 were shocking. So a patient could wait out anything from 1 to 4 hours for what's called a category 2 emergency, which is where people are really, really sick and need to be transported to hospital within 8 or 9 minutes. Wait times could be anything from 1 to 4 hours. Because of the delays and the complexity around infection control and so on. So I just wanted to give those 3 anecdotes to give a sense of what people were dealing with. But going back to innovation, Pramod, just 3 very quick things. Overnight, consulting with patients switched from face-to-face telephone or video consulting overnight. In the UK, the plan was to implement digitally led consulting, over a period of years. That happened probably for most care providers over 3 or 4 days. So all of the technologies that were being debated or considered in the run-up prior to the pandemic were overnight almost approved and suitable for use for teleconsulting and telemonitoring and consulting with patients. In my own practice, we used to see 80% of our patients face-to-face and 20% of them remotely by telephone and very, very occasionally by video, hardly ever. Overnight, that switched to 80% remotely and 20% face-to-face. So that happened within 12 to 18 hours of awareness of what was going on. The other innovation I'd like to point out, Pramod, before we, as we go in, that for the medical community in the UK, there's always been a sort of sector rivalry between primary care and secondary care. So hospitals and community clinicians. Traditionally, there's been some sort of issues about how we work cooperatively. Again, very soon, because of the pandemic, we became one family of clinicians, so that actually hospital doctors and primary care doctors, hospital nurses and community nurses all saw themselves as being one team and actually started to work together to look after sick patients, whether they were in hospital or outside of hospital. And I would say that's an innovation, Pramod, because we're still trying to make sure that we pick that up as a way forward as we move forward in the system. And obviously the final innovation that we can talk a lot more about beyond teleconsulting is just starting to introduce a range of remote monitoring technologies for people to be looked after at home in terms of oxygen saturation, blood pressure monitoring, and reporting of symptoms, so they didn't actually need to come into the clinic if their monitoring statistics were satisfactory. I'll stop there if that's okay.
No, thank you, Nav. And just so, in some ways, there are so many similarities between the experiences. I think that's true anywhere in the world. We didn't know what we were dealing with. Any preparation was due to fall short and fell short. But then there was, the response from the life sciences community, the vaccine manufacturing and the pace at which vaccine development happened has been, again, unprecedented. And India is, at the forefront of vaccine manufacturing. It'd be good to spend some time, and I'll start with Varsha to explain how, what was your perspective in terms of when the vaccines were developed, and also in the lead up to that, how were you preparing, and what was the sort of rollout, and what were the challenges?
Yes, I think this was the time when the vaccines were prepared in a record time. And all the steps were taken very fast, like even the trials which are required for the vaccines to be actually launched and given. So that all the steps were very fast. In India, at present, we have 3 vaccines which are given: Covishield, Covaxin, and Sputnik. So the rollout plan was also very good. And even digital CoWIN app was used. So in the beginning, it was started only for the healthcare workers. That was on 16 Jan 21. It was started first in India. And 2nd February, the other healthcare workers and frontline workers were included. From 1st of March, we also started for senior citizens more than 60 years, as well as those who are more than 45 years with comorbidities. Now, these comorbidities were 20 listed and they had to be certified. So it was done very systematically. And the thought behind this was those who are more at risk should be vaccinated first. Then later on, from 1st April, it was open to all who were more than 45 years. And recently, after that, from 1st May, it was for more than 18-year-old. And now what we have seen in this year, 2022, there are two new things that have happened. From 3rd Jan, the vaccination was started for 15 to 18-year also, and that is the co-vaccine which is given to them, while a precaution dose is started for those who have taken the first 2 doses, and that is given after completion of 90 days of the 2nd dose. So most of the healthcare workers have already been given that. So this, our plan is little different from what is followed in other countries. I'm aware of that. The challenges faced, firstly, our population is such a huge population in billions. So to produce vaccine which is enough for the population, it itself is a huge challenge, but that also has been met with. The second challenge was delivery of this vaccine to so many people all across, and not only in cities, but also in the villages. So for that, this rollout plan, as well as the storage of vaccine, the cold chain, everything was meticulously planned, organized, and followed also. The third challenge, which is still a challenge, is there are some beliefs and thoughts where there is some communities or some villages, they don't accept vaccination. So they're reluctant for vaccination. So that is a challenge. So that has to be overcome, and also efforts are being made for that also. So let us hope that we could vaccinate. We have managed more than 1.5 crore vaccinations, and majority have taken at least first dose of vaccine. And another thing I just want to add here is I'm a pediatrician. So we were thinking that later on in the third wave, the children will be affected very badly. But fortunately, we have not seen that. Still, they are having mild illnesses. So that is our plan for vaccination, and few more vaccines may be coming. So they are still under trial. So that is the scene now.
Yeah. And we'll come back to that, I mean, about the issue of children also, because I recall the commissioner in Bombay planning a lot of inpatient sites with facilities for families to also be there, but we are fortunate we haven't been there. And this point around vaccine hesitancy or refusal of vaccines is interesting. Can I go to Belgium? Hendrikje, what's your experience been? You've been directly involved, and you had to change your role during this period, right?
Yeah. In Belgium, we had an opportunity because the first line consoles in Flanders were installed in May 2020. So they changed their task to managing the COVID pandemic. And that was the contact tracing and the management of the contact tracing, but also the vaccination. So the government gave the vaccination program to the first line councils in cooperation with a local government. Now for Leuven, that was easy because we have one government, the city government of Leuven, in our first line health council. But in other health councils, they had like six or seven local governments. So that was difficult to start campaigns. We had to build and create our vaccination centers. Where were we going to put them, who will be working in them. It was a big study and a big challenge for us. And we had another problem with the delivery of the vaccines. Our government was a bit late with ordering the vaccines, so we just got them really, really gradually. So we had to work with 4 different vaccines. We still work with Pfizer is our biggest vaccine for the moment, and then Moderna. But we also had AstraZeneca and Johnson & Johnson. And with AstraZeneca, there were a lot of problems in the beginning, which was for us difficult because of all the problems with the vaccine. Our inhabitants were a bit reluctant to get a vaccine. There was also a lot of misinformation on social media. We had to battle that as well. That was a big task. but we managed it, and we started with the 85 plus inhabitants because they were the most vulnerable of all of us, and the healthcare workers. And then we defined a group of risk patients in Belgium who got their vaccine first. That was also a challenge because we learned that we have a lot of databases in Belgium, but they weren't connected. So like the healthcare funds, the government databases, the hospital databases were not linked. So it took a while to put together the target group of the risk patients. And I give you an example for what went wrong. Like we searched in the databases for people who had an inhalator with cortisones. So we had a lot of people coming to the vaccination center who had an inhalator with cortisones, but had them for like 1 week in the last year. And all of a sudden they were a risk patient and they get vaccinated first. So it gave a lot of worries with the public for when it's my turn, I'm a risk patient and I haven't been vaccinated yet. So it was a real struggle for us. But we gradually moved on. So we started to vaccinate the whole population of the 18 plus, but we went from the older to the younger populations gradually. Then we decided to vaccinate the children, the youngsters between 12 and 18. And now for the moment, we are vaccinating children between 5 and 11 years old. And we are giving a booster to the 18 plus children, to the adults. And there's a big discussion going on in Belgium for the moment because the group between 12 and 18 years old aren't getting a booster yet. The European the EMA hadn't decided yet if we can give it. Some of our countries, other European countries, are giving boosters yet, like France and Austria. And France and Austria are the biggest ski countries for the Belgians. So now the children want to go skiing, but they cannot go to France or Austria because they didn't have the booster yet. So it's a big political discussion for the moment. Are we going to wait for the advice of the EME, or are we just going ahead and start boostering the 12 to 18 years old? So that's where we are at the moment in our vaccination campaign.
And what about challenges, referring back to Dr. Varsha Phadke's comment about hard to reach groups, misinformation? What's been your experience, Hendrikje?
We have a lot of misinformation in Belgium from the anti-vax community. It's not a big community in Belgium, but they have a big voice. We also have demonstrations against vaccination and against all the COVID rules in Belgium. We've heard the most incredible stories that were told to people, like in our African community in Belgium. There was at the time the big misinformation that women were getting infertile from the vaccine. So it's very hard in a population where having children is a very, very important thing, to convince those women to get the vaccine. That were really big challenges. We have also a lot of illegal people in our country. How are we going to reach them? We have homeless people. We have our families at risk. How are we going to reach them? So there were a lot of challenges, not only to convince the people to get vaccinated, but also to reach very specific target groups to get vaccinated. We also have a lot of residential facilities in Belgium, like for the elderly or for people with a handicap. How are we going to reach them? So we also created mobile teams, not only vaccination centers, but mobile teams from doctors and nurses and pharmacists who really went to the residential institutions and vaccinated the people there. So that was also a challenge we had to face. And for the moment, we are still investing a lot of our time and energy in reaching out to these target groups, to these very specific groups.
Thank you, Hendrikje. Hanif, you were in central government at the time, leading one of the key strands of the government program, the events program. What was your sense of how it was being driven centrally? What were the key considerations for the government in terms of the vaccine rollout?
So we also, just as Hendrikje has described, had a stratified response. So we also said there would be, the elderly, the most vulnerable first, and then coming down in, I think if I remember rightly, age groups of 10, so 65 to 75, 55 to 65, and so forth. And then as we descended into younger people, that age group just expanded rapidly, just to try to get the vaccine rollout going. The government response was really balancing between the political requirement about opening up the country economically. There was a lot of pressure from lobby groups around industry, around the retail sector and so forth to get the economy going, the travel sector very much so, balanced against controlling the pandemic essentially. So there's something called SAGE, which was long established. It's a non-standing committee, but it kind of forms when there is a requirement for it to form, and it's the Scientific Advisory Group on Emergencies. And there was a lot of debate going on in the public. You had lots of directors of public health coming on to television, criticizing the government response, very much so. And then there's a lot of stuff around, are we following the data? Are we really making these decisions based on good scientific evidence and so forth? So there was this continuous debate on television. And as you probably know, in the UK, we always enjoy bashing our politicians and government and so forth. So it's quite an open debate. So to the remarkable extent that SAGE decided, because it was advising government ministers on what the course of action ought to be. And as part of SAGE, there's also something called JVAC, which is the Joint Standing Committee on Vaccinations and Immunizations. In May 2020, unprecedented step they took of publishing their minutes. So from May 2020, to make it as transparent as possible in terms of what the advice being given to ministers was on immunization and vaccination policy, the minutes became online so that everybody could see it, access the online debate. And there was this whole kind of thing in the government, as you probably remember, if you're watching the news in the UK, it's about data, not dates. So we're going to start to ease economy and open up the country as the vaccine rollout happens, but not based on dates, which were being given on a daily basis, saying we will open up the economy on June of this date or July of this date. Everybody was saying we need the data first to kind of understand what's going on there. So the government response was very much looking, I thought it was becoming very mature at that point, where the debate was much more around the public health balanced approach to risk, and the liberal attitudes of our existing governments, which is around personal freedom to decide and choose what to do. But there are sectors within our communities, within our industry, where now vaccination has been mandated, for example, in the NHS. So it's called vaccination as a condition of deployment, VCOD. So if you're a frontline healthcare worker, you have to have the vaccines. Otherwise, legislation now, by the 1st of April, you will be removed from frontline service. You will be dismissed if you cannot be deployed. A very big contentious issue being discussed now. But I'll go back slightly again to SAGE. So in May 2020, the government response was essentially saying, here's the data. This is the advice we are getting, and we have to do what we think is best for the country and best for the population and best for the individuals. So there's a part of SAGE has something called the modeling. So there's something around, it's called SPIM, which is the acronym, the worst thing that you can think of. But it was called, it's around disease and epidemiology. It's around modeling. There's also something called NERVTAG, which is a committee around new and emerging respiratory virus threats. I can't remember the last part of it. And then there's something around behavioral scientists as well. They were also involved within this entire committee. So what the government essentially did was they pulled together some of the leading thinkers in all of these areas and all the scientific evidence around epidemiology to form policy advice. So I used to write policy advice to ministers, perhaps when I was in the department before the pandemic. Once every 2 weeks, a policy note would go up. We were writing about 10 a day. So as the pandemic is progressing, because there was so much changing on a daily basis that the government was essentially asking every single day, is this data still valid? Is this response still the right course of action? And every day around 5, maybe 6 o'clock, the Prime Minister would come to the television and say the latest figures, but also then give the latest advice that they are receiving to evidence the decision that's being made on that day to be enacted for the day after. So that's how live the whole scenario was in terms of vaccines. I'm not as qualified as my esteemed colleagues on the panel to talk about the vaccines in terms of the ones we have, what the efficacy is and the rollout. But in terms of the policy response on vaccinations, that's where we were. And just in terms of innovation, just picking up on a point that Nav made earlier, one of the other key uptakes within the United Kingdom was the NHS app. So we had this app that was developed, and very few people in the UK want to share data, health data particularly, electronically. It just wasn't just done. But when the app was launched and it became a condition of entry into venues to show your vaccine status, everybody started downloading it. Now millions upon millions have downloaded the app, and it's the COVID passport, as you probably recognize it. But other two key setups within the government was, during the time of pandemic, what don't you do? You don't disestablish the very function that's the expert on controlling pandemics, which is Public Health England. So during the pandemic, we decided as a government to disestablish the very function that's the expert on this, and subsume it into something called the United Kingdom Health Security Agency, UKSA. There's also something called the Office of Health Improvement and Disparities. That's a specific response because COVID essentially, and because of the vaccine program and rollout and the opposition to vaccines in certain communities, for example, the misinformation out there, it exposed not only the response to COVID in terms of how certain communities were, the mortality rate was much higher in certain communities, but also the hesitancy in terms of vaccines, in terms of miscommunication. So Professor Chris Whitty, who's our Chief Medical Officer, underneath him, he set up a new Office of Health Improvement and Disparities, where these kinds of things are now being discussed. And its main purpose is to break the link between the background of an individual and the prospects for a healthy life. So these are some of the other innovations that have happened as a result.
Thank you, Hanif. And that's a very important point around how the impact has been of COVID. And there was a publication last year with an update this year, this year, not late 21, on the unequal impact of COVID. And in the UK, certainly all the populations that were marginalized, either due to socioeconomic factors or due to disability, mental health issues, they were more impacted by COVID. And again, the vaccine take up in those communities were very, comparatively very low. If I may ask you, Dr. Phadke, the vaccine misinformation, the hard to reach groups in India, what tactics or what strategies work for those groups of people, if you had any examples in mind?
Yeah, there were in certain villages, there were some villages felt that nothing like COVID exists. So that was one. Second was, as mentioned earlier, infertility. So that was one misconception. So how it is being tackled is, now every village will have a head, and there will be local communities who will have somebody who will represent them, and in their local language, if anybody can explain to them, communicate better with them and convince them. So that is the way it can be done, because somebody coming from outside and trying to convince them, it is very difficult. So that is the strategy which is being tried now for the misconceptions, and especially for this group. Another thing here is, you know, a lot of the Ayurvedic medicines, homeopathic medicine, people feel that if they take, their immunity will improve and they don't need to take vaccine. So that is another group of people where they are reluctant to take vaccines. So that is again very difficult to convince them for vaccination.
And I know that in Kerala, in the south of India,
Yes.
the state government is distributing homeopathic medications,
Yes.
And has been doing so in parallel with vaccination and other efforts. So, you know, it's almost an integrated form of medicine in India. And now, what are your thoughts, you know, from frontline as well as national level? Any insights you have on the hard to reach groups, or, you know?
Yeah, so I think when we're talking about strategies to hard to reach groups, whether it's vaccination or any other intervention, the important thing is that you don't take just a one size fits all approach to everybody. Okay, so I think there's a sort of common misunderstanding sometimes that everybody accesses information and the health understanding is the same, and of course we know that's not the case. So strategies need to be multifaceted and specifically targeted to and around the needs of those particular communities. So we've seen some very good examples, and obviously one of the advantages of the UK healthcare system is it's a state-funded healthcare system. So the idea is that people can access and uptake interventions without needing to pay, and that's an important element of care delivery. So what we've found is that we've got some great examples where doctors or nurses are individually phoning up patients who were hesitant and having conversations with them. We've had volunteers doing this. We've had role models from the community, whether they're religious leaders or sports icons or media celebrities, also targeting through a variety of campaigns. We've had people knocking on doors. So it's a variety of interventions that come into play. And it's important to kind of stress this, because health inequalities, which essentially means different groups of people have different health outcomes, essentially has been a problem in the UK and recognised in the UK for many, many years. But generally, not a great deal has been done about it. And the pandemic, certainly the early phase of the pandemic, as Hanif was saying, highlighted the shocking disparity in those that died from particular groups of people with social, economic, and financial need, but equally those from particular ethnic and cultural backgrounds. And if you look at the doctors who died in the UK, the largest proportion of those were people from Black and ethnic minority backgrounds. So it's not just so this is a complex issue. So I guess, Pramod, to answer your question.
Now, one second, could I ask you to just give a sense of how that health inequality, you know, any quick numbers, because you talk about this and you worked on this for many years, not pandemic related, but just the sense of life expectancy difference or quality of life difference, just to expand on that.
Yeah, so there's, you know, we know that 20% of people roughly in the UK who are from the most economically and you know, I hate to use the word, you know, populations which are deprived, because that sounds very negative, but, you know, populations which have different needs, but which can be categorized by indices of deprivation. So you take the bottom 20% and we can identify those groups, and we can identify those people have the worst health outcomes. Pramod, and life expectancy differences can be anything from 7 years to 10 or 11 years, depending on geography within the country. Now, that may not sound very alarming to people, but it literally means that you can go from one part of an urban town like London, you know, and 400, 500 yards or meters away, there may be another group of people whose health status changes dramatically just based on the conditions in which they are living, whether they're housing or economic, or whether they're related to crime or lack of green space, or, you know, whatever the kind of broader determinants are that play through. So it's so important that when we think about health interventions like vaccination, that we just don't see that in isolation, that we've got to start thinking about all the other determinants of health and how we design systems that will address those in time to come. Does that make some sense?
No, thank you, Nav. And may I ask you to, so what have we learned from, we've had the impact of the pandemic, vaccines, non-vaccine intervention, but, what have we learned? There's been a number of things that we have learned, and we can solidify that. But from your perspective,
Yeah, so sorry to interrupt. So basically, the COVID vaccination program, then, just as Hanif was outlining, is a great example of population health management. So it's a way of thinking about your population, whatever it is, thinking about those with different needs, and in the context of the vaccination program, as colleagues have said, that was based on health priorities, health needs, maybe age. And other comorbidities. So that is, and people talked about stratification. Essentially, the language of population health management is segmentation, which is grouping people by need, and then identifying health interventions that are tailored to those groups of people. So the vaccination program itself is a great example of population health management in action. So the question then is, how do we take the learning away from that into other things? So we've just said that different groups of people have different needs, and we can't target them with a one-size-fits-all approach. So when we start to think about non-communicable disease management, hypertension, diabetes, maybe cancer care, we really need to start thinking about identifying groups of people at risk, who we know have particular needs, and making sure that the interventions and the way we present them, the way they access them, are designed in a way that kind of improves and will sustain their health status going forward. Now, we've known this for many, many years, Pramod. This is not new stuff. People have been talking about this throughout my medical career, 35 years. But it's only now, I think, the impact of the pandemic has sharpened and focused these conversations to such an extent that I think we're going to get a much better prioritization of how we spend and commit our health resources going forward.
Can I ask one question, Pramod?
Sure, please come in.
So my question is very simple, that the way we tackled smallpox or polio by mass vaccination, either by you making use of community health workers or by door-to-door delivery of vaccination, or we could convince population much more effectively the utility of that vaccination. So why it is so difficult in case of COVID? Why we are not able to convince still the utility or effectiveness of COVID vaccination? What is the same? Is there any reason for that?
Who wants to go first?
Yeah.
Yes.
Yeah.
See, Dr. Prema, for all vaccinations, there will be a group of population that are reluctant to give the vaccine. Now, for polio, as you said, it's the easy part is there is a lot of herd immunity involved with the oral vaccination given. So even if you vaccinate majority of the population, the others also get that. So that is one thing. Then about COVID, I think we are still going in phases. So we have not yet planned to give the vaccine to all, including children. So there may be a time when we should be able to do that. Maybe it is early to say this.
True, very true.
Okay.
Pramod, may I just,
yes,
Pramod, that's a really good point. I mean, it's really hard to answer that precisely. I think COVID, in many people's eyes, is a silent illness. Unlike other communicable diseases, which can be more visible and the impact can be more easy to see. Sometimes with COVID, it's perceived by some communities to be a silent illness. So it's not that easy to differentiate it, say, from coughs, colds, and other viral infections that are prevalent. I think that's quite a strong factor as to why some people are more hesitant than others. The other things are, I think colleagues were reverting to that. We're in the age of social media, and even for those people who are not able to access social media through digital poverty, the word still gets around, and the number of myths, as Hendrikje was saying, that have been propagated, some of them are really still quite strong. I mean, the issue of fertility in particular groups of people is still a very strong factor for hesitancy. And there's also other things such as conspiracy theories, which are, that this is part of a national campaign to either, target people in particular ways, or to introduce particular, DNA mutations into their kind of into their genetics. Now, these are quite hard to challenge, because they're so entrenched, and the social media circuit keeps throwing these sorts of things up. So it's a bit about the silent nature of the virus. It's a bit about the way that myths are being propagated. It's a little bit about access and uptake, and we said that earlier, didn't we? And it's a little bit about how particular communities worry about national campaigns and things like that in terms of their civil rights. So there's a number of factors that are coming into play. Sorry to go on about that.
And we've got Hanif and Hendrikje. Hanif, you've had your hand first. Do you want to go next?
Yes, I thought I'd I'd use the lower hand and upper hand kind of scenario here, just see if it works really on Zoom. All those things that Nav has just mentioned, absolutely very well articulated. I thought one other thing I would add is that everyone became a very big expert on how a vaccine is developed in the UK. Everyone, from the person on the street to the genuine people who actually are trained in this. I think it was the speed of the development here which caught a lot of people by surprise, and therefore there is hesitancy to say, vaccines from our own background and history take years to develop, clinical trials involving hundreds of thousands of patients, and then evidence is published in terms of the side effects or long-term effects. And I think there's a lot of hesitancy, certainly in the communities that I speak with. And what I mean by communities, in my sense, is the professional communities that I work with, is about it just happened too quick. We don't trust it. We don't know the long-term effects. And so there's some hesitancy, particularly from professionals around, it's just not enough evidence really to say we can do this. And I think just to talk about a little bit controversial here, communities within the UK who have or were part of, for example, the colonial history, as it were, of the United Kingdom, there is perhaps some historical evidence to suggest, that the vaccines and the rollout and various other bits and pieces, communities have got a historical context that they are deploying here within the UK to say, perhaps this is something, rightly or wrongly, there is this kind of historical memory as well around communities which are legal, but immigrant communities still considered, within the UK. And there's some sort of hesitancy around something being done to you and so forth. I get that sense as well. Yeah.
That sense of trust is not there with leaders. Hendrikje, please come in.
I wanted to add the same point. We also saw in Belgium that we went to a really accelerated process, and that gave a lot of resistance with the public and a lot of mistrust, a lot of urban legends who started living their own life. And I think that was one of the key elements to the mistrust by the public, because the process went so fast. Normally it takes in Belgium up to 3-4 years to get a new drug approved. The COVID vaccines took just only months. People were asking questions about it. And like it was said, everybody was an expert overnight in vaccination. So there was, I think that the really accelerated process was one of the key elements.
Yeah, no, absolutely. And Prabhakaran, to your point again, even within the professional community, there are a significant group of people who haven't had the vaccine. And I know colleagues within my team. Who have died in the pandemic. Who we operate in small mini teams within the service. So people are aware of colleagues who have been affected and died, yet there are significant number of people who are not vaccinated. And now, and if you raise the point of mandatory vaccination, so since last November, to be a care worker, are you working in residential or care homes, you had to have been vaccinated, and you lost employment, not redundancy, lost employment. And that's coming to the National Health Service with 1.3 million or maybe more staff from the end of March. So from April, everybody has to be vaccinated, otherwise they lose employment. And I think it's a good time to segue into some of the moral ethical concerns around, and also practical issues around mandatory vaccination. Hendrikje, can I ask if there are moves towards mandatory vaccination in Belgium?
For the healthcare workers, we have the same scenario that they have to be vaccinated before the 1st of April, or they lose their job, or they get suspended for 6 months from their function. Now, it's still a very big political issue. There are still political parties that are fighting against that decision. The other one that is still on the table in Belgium is the mandatory vaccination for the whole population. And I think we were more going over to the side of, well, we will do it. But now with the Omicron variant, we see that the virus is getting less sickening, it's getting less worse. So now we have more and more questions about, can we make it mandatory? But it's still on the table in Belgium to make it mandatory for everyone.
And Austria, it's mandatory. They've passed it, isn't it? They've approved it. And in
but
India,
in Belgium, they almost make it mandatory, because without a COVID safety kit, you can't do anything in Belgium anymore. You can go to a restaurant, or you have to get tested before you go. You can't go to the cinema. You can go to concerts because you have to get tested before. So like it's a bit of a back door to ensure that people get vaccinated. And we see that in our vaccination center. For the moment, we still get people who want their first vaccination, and they are very angry at us sometimes in the vaccination center because they say, yeah, well, it's not mandatory in Belgium, but it is, because without my vaccine, I'm just condemned to stay at home.
Yeah. And what's the situation in India? So there's two things, right? The vaccine, almost the vaccine passport thing to get in anywhere. And then the issue around mandatory vaccination, even for healthcare groups. Are there any moves like that in India?
Again, it is not compulsory, but at many places, we have to show the vaccination card. And to travel abroad, and also that everybody knows that the rules are very strict about that. But within the country also, but it is not made mandatory, and I don't think it will happen in the near future to make it mandatory.
Okay, no discussions at a government level on mandatory vaccination. Okay. Nav, please.
I just wanted to make a quick point, Pramod, on mandatory vaccinations, because this is, as we know, in the English NHS, a really hot live issues, and the 4th of February is the date, unless government changes its policy, where all hospital trusts have to make significant decisions about staff deployment and the way that services are run. Based on my experiences in Southwest London, we think about 10%, roughly on average, about 10% of hospital staff are not yet, it obviously varies from trust to trust, but overall, that figure might be the right sort of figure. And whilst that may not seem terribly, much of an issue, unfortunately, it seems that a lot of those staff are in some of the high-risk specialties, such as accident and emergency, maternity, trauma and orthopedics, some of the high intensity specialties where the demand is already very, very high, and we're already struggling with the workforce, whether you take the vaccination issue or not. So I guess the point I was trying to make is that if this policy goes ahead, notwithstanding the ethical issues around civil rights and employee rights, I think there's going to be a real difficulty in running services, emergency services particularly, in some of the acute specialties, in some of the big trusts. I think there will be such an impact that is going to be quite hard to kind of provide in the way that we are doing at the moment. So I wanted to make that point in terms of how we run future services, because it's going to be quite significant.
Absolutely. And I'll come to the point of, what does the future look like in a second, Nav. Hendrikje, your thoughts?
Yeah, I want to add one thing about the mandatory vaccination of the healthcare workers, which is what is astonishing in Belgium is that we already have one mandatory vaccine for our healthcare workers, and that's the hepatitis vaccine. There is no dislike to that vaccine, and we think it's because it's threatening for the healthcare worker in person. If they get hepatitis, they get sick, and COVID is a bit further away for them. So we see also vaccinated healthcare workers for COVID who are against the mandatory vaccination in their profession. But if we ask them then would you like to abolish the hepatitis vaccination as well? Oh, no, that has to stay, the hepatitis vaccination. So we see a discrepancy between those two vaccinations.
And probably some of the reasons are what we already alluded to, the speed with which the vaccines have been developed and actually the variety of types of vaccines in this regard. Hanif, you wanted to come in on this point.
Yeah, just a quick point, really. Picking up on something Nav said earlier as well. Workforce really is, healthcare is a people business. No matter how much technology we have and enablers, etc., and the apps and all those kinds of things, healthcare really is, and you alluded to it, 1.3 million people employed within the NHS. It's, I think, now the 5th largest in the world in terms of employment, the Chinese state army first, I think Indian state railway second, Walmart third, and various other bits and pieces, Amazon probably fourth. But NHS has, always been seen as a national institution employing usually the largest employer in a town in terms of a hospital and so forth. So workforce really is the rate determining step in terms of our ability to succeed in managing this pandemic and as it transitions into an endemic situation. So there has been a paradigm shift here, really, in terms of the way we are managing population health. I think that was very well described by Nav. And I think the challenge now is to lock in these changes before we lose them from a structural response perspective, and I think, this workforce is such an important issue, even within my company. I mean, to lose the figures I'm seeing, to lose 60,000 staff at the end of March is a significant thing, very, very significant, particularly because 2 years ago, we were all standing on our doorsteps and clapping for the staff. And now we are saying, now you have to leave. It just sends the wrong signals, I think. But also there must be a different, more intelligent way of overcoming this issue. And I don't know what the answer is, but there must be some other ideas in the world that we should be looking at or considering, in terms of an approach, a social legal approach to this, perhaps, But yeah, I just wanted to raise the fact that this is really the rate determining step for us.
Can I was going to go around the panel and ask each person for their thoughts on the key. One is how to lock in the learning. And the second part is, what do you see as the key themes around COVID recovery and how do we prepare for the future? Can I just start with you, Hanif, given, you just described some of that? No.
I think I just said I don't have the answer.
I know.
I think I have some thoughts, though. I mean, the structural responses, I think, there's some government structural responses in terms of the things that I mentioned about the Office of Health Improvement and Disparities, which has now been set up largely as a result of, I think, exposing our failure in the UK to tackle a pandemic. I think the fact that there is a pandemic, I've always said this, is no surprise, because there's always one pandemic around the corner. I think it's our inability to manage it and deal with it has been what's been exposed, really. And I think the public have seen also that, there is this weakness in the system, having dealt with this currently, but also largely a very healthy debate also within the UK. People not afraid to say what they need to say and want to say and so forth. So I think there's also this healthy debate. I think in terms of road to recovery, locking in the innovations around, for example, the digital consultations, the fact that young people, the fact that social media, people are are not averse to using these technologies. I think also within social care, domiciliary care, etc., probably the largest workforce in the country, who are carers, visiting people, elderly people, and so forth on a daily basis, their ability and use of technology is just underserved, at the moment. So locking in some of that, using the NHS app much more widely, using digital consultations, I think that is a great innovation. I think we should lock in and how to lock it in. I think it should be just legislated going forward, making it easier. There should be funding available. There should be R&D. There should be clinical trials involving some of these uses in terms of managing how things have progressed. Some of the work we did in the past, I was involved in, called the Events Research Program, which was about understanding how people who were vaccinated and people who are not vaccinated attending large-scale events. Some of that research that's come out from that needs to be codified and created into policy. So I think smarter policy making by people who've got the right level of experience is perhaps something that we ought to consider across government and Whitehall departments. And I think finally, just the fact that, we responded with, 4 key areas which were completely chaotic, which was around the PPE procurement. That should never happen in the future. We should be localizing manufacture and things of that sort within the UK. The fact that there was a worldwide call for development of ventilators, again, that is something that countries ought to think about, having that capability within their boundaries and borders. I think the fact that we were able to stand up and then not utilize Nightingale hospitals, breaks the paradigm of how long it takes to do something. And where there's a will, there is a way. We need to lock that will in somehow. And finally, we created the largest testing laboratory infrastructure, I think, post-war anywhere in the world, within a matter of months. Again, showing that where independent sector, commercial partners, the pharmaceutical industries, where we come together, things can happen very quickly. And I don't see why that cannot be business as usual.
True. No, that's excellent. Thank you, Hanif. Can I go to India, Dr. Phadke, your thoughts on, how do we lock in what we've learned and what are the key themes for us going forward?
Pramod, just 1 minute. Dr. Katherine Careaga has also joined. So she's from New Jersey University, USA.
Fantastic.
So if you want to invite her for US different perspective, she's already there.
Brilliant. Disappeared. Brilliant.
Hello,
hi,
thanks.
welcome. Fantastic to have you around. So we just really going around the panel, asking how do we lock in what we have learned during the pandemic, and what are the key themes in terms of the road to recovery. And we are in India with Dr. Phadke on this point.
Yeah. So there are a few things. One, as mentioned, we have to improve the healthcare facilities that are required. I think what we have learned in the pandemic is it is possible to do it, and we should be prepared beforehand for such events. So we have to plan in advance, which we were not at all knowing what we are supposed to be doing for this. So the infrastructure is there. Then training of healthcare workers, that is also extremely important, which includes not only doctors, but nurses and all the healthcare workers, including the laboratory personnel, all that. So this training. So here I would like to say one thing is our National Medical Commission, which controls the medical teaching across India. There is a compulsory skill lab should be there in all medical colleges. So now last year what they have introduced, there should be a separate COVID skill lab also, which has become mandatory. So automatically everybody will be trained in the COVID skill lab also for the actual hands-on training, which they can do it on mannequins and videos, all that. So then another challenge is the online and offline teaching. Most of the medical students, they had to undergo online training since last year and a half. So that was a difficult thing because medical student has to actually learn by seeing the patient. They could not go to the wards. So that was what was lacking. When the same batch came to do their internship this year, they were all wanting to go to COVID ward and work there. So that is what I would like to share this experience, which otherwise they would like to go to other departments, but they said, no, we want to work in ICU. We have to share this experience because we have to manage patients. We have to learn that. So that is about the training. This I am mentioning because I am involved with a medical college. So training also and also the patient care. So both we have to plan and prepare. So I think that is one of the points of taking it forward.
I'll come back. I'm very conscious that Dr. Nav Chana has to leave in a minute. Now, your quick thoughts, and then I'll go to the rest of it.
I do apologise. I have another meeting in a few minutes. So just to say a couple of things. So I want to signal to my colleagues on the call that the next global emergency is in my view to do with climate change and the impact of that. And we are all experiencing health consequences, whether it's pollution or other environmental causes to ill health. So I wanted to signal that what we learned during the pandemic, particularly during lockdown, was an incredible impact on the carbon footprint of healthcare providers, partly because people were not accessing care, and partly because the access was being delivered in a different way. So Pramod, I want to kind of offer the learnings of that going forward. And I would like to focus everyone on 4 things that I've learned about how we might help to address health inequalities as a consequence of our future healthcare provision. And we've touched on these already. So the first is understanding and identifying the health needs of our people or our patients in particular situations, in particular communities, because they are different. And if we don't understand them, we can't shape the design in the right way. The second thing is thinking about how we access and uptake services, whether it's vaccination or any other intervention. Again, that varies by need and by design, and technology, as we've said, can play a significant component to that, but it's not the only solution. The third is focusing on the quality of the interaction between the healthcare professional and the patient or the carer. Okay, the quality of that interaction, and making sure that, again, health needs, the way we communicate, the way we take into account things are absolutely integral to that. And again, technology may help us with that. And then the final is how we support people to look after themselves better in an empowered way, and making sure that actually unnecessary healthcare contact is managed in some way through some of those approaches. And again, technology can play a part in that. So I guess those would be my lessons learned and the lessons that I would wish to take forward in terms of healthcare service design in going forward.
Thank you so much, Nav. And I know you have to leave, so I'll say goodbye on behalf of the panel.
And just say thank you, everyone, for listening to me, and
so
have a good evening, afternoon, and evening to you all. Take care.
Thank you so much.
Thank you. Thank you. Who would like to go next? And Hendrikje, would you like to go?
Yes. One of the biggest lessons we've learned in Belgium is that we didn't have sufficient emergency scenarios. And now we have them, but we still have to make them more coherent. Every profession has now its own emergency scenarios, and now we have to make them to combine them and make them coherent in a large emergency scenario. Another thing that we learned in Belgium, well, before the COVID pandemic, there were already a lot of voices raised in Belgium to reorganize our healthcare system. We had a very strong and good healthcare system, but it's a little outdated. So we have to reorganize that. COVID learned us that we really have to do it in a fast way. What's very positive about COVID is where the reorganization of our healthcare system used to be on a very high level with experts. Now our politicians have learned the lesson that they really need to address also the field workers. So now in a lot of debates, nurses are involved. So that's a positive step in our healthcare organization. We need to hold on to the digital approach of healthcare, and COVID really made us work together between, and it's already mentioned here, the collaboration between primary and secondary healthcare is a lot of better since COVID, but we need to hold on to that. It's not because that the pandemic will go away that we have to leave all the alliances that we made behind us. So that's a very big challenge and lessons for us to go further up on that road of collaboration.
Thank you so much. Thank you so much. And I said, Dr. Careaga, Katie, yes, please, your thoughts. Thank you for joining us.
Sorry, I actually don't have any wise words of advice, and I'm sorry that I'm coming in the middle. It's very early here, but I'm humbled. I'm joining from, you know, probably well, the worst developed countries' health system, and so it's been really interesting to listen to your experiences in other countries. And I do have some questions, but I'm just wondering if you want to wrap up with the other speakers before I ask those questions.
Yeah, no, that's great. I mean, I just asked the other speakers if there were any further points. And we can start with your questions, and then we can take questions from the audience if needed.
Yes, sir, sure.
Yeah, perfect. Okay, please go ahead.
Yeah, well, I mean, I think somewhat to add to the other speakers' points, I absolutely agree and was happy to hear, I think that especially for our system, I think COVID is hopefully raising consciousness about the urgency of reform in our healthcare. I'm not convinced that how far we'll get with that, but definitely I think we're speaking the same language. I'm coming from medical anthropology, and my doctorate is in sociocultural epidemiology, so really kind of a lifelong interest in the social determinants of health and health disparities, and how do we approach those, particularly how do we bring in all of the social science, not only knowledge, but methodologies and place-based methodologies. So this is something that, again, I feel like, there's a much larger and increased consciousness of the need for more maybe ethnographic and inclusive approaches now, hopefully, rather than years ago when I've been studying this and teaching it. And so I guess some of my questions, a lot of my research has been around sexually transmitted infections and HPV, not only vulnerability and sense of vulnerability in migrant populations, immigrant populations, but also now, vaccine hesitancy around HPV. And, this is another thing where I'm in awe of the UK health system, where, I think there's been a lot less hesitancy around HPV vaccinations. And a lot more uptake and rollout than in the United States. And so I'm wondering, first of all, if there is either implementation or consideration of kind of multi-vax campaigns. I'm also wondering about adolescent vaccination or like pre-adolescent vaccination, including COVID, because I know for us in New Jersey, we are now children are eligible after 5 years of age. So I'm not sure where other countries are at in that process, and that implies, right, dealing with parents and convincing parents to consent to their children, which is sometimes different. Certainly, we've observed differences, depending on the vaccine. In the interviews that we've done, we have varied hesitancy, right? And I think the approach that we've taken is that hesitancy is understandable, and we're trying to understand that rather than kind of labeling people as hesitant. Yeah, I guess I wonder, I was really happy also to hear, because for my, the presentation that I was preparing, I have also made that comparison, not partly to smallpox, but actually what I've noticed in social media is a lot of memes going around talking about how polio is eradicated by pro-vaxxers. And I'm like, this is not accurate information. Polio is not eradicated. And I started thinking about, the pitfalls, right? And the really, again, we kind of dismiss things as conspiracy theories, but, particularly in the case of polio in the subcontinent, and Pakistan is one of the countries that where it has not been eliminated, which India shares a border with. Our government, the U.S. government, had the CIA, doing fake polio vaccinations, and so understandably, just there is this track record where trust has really been violated, and so. Yeah, I guess I'm wondering if people could speak a little bit more to, I mean, particularly in India, that's my question, is just like, I do think that there are definite lessons learned from what was done well, and also what was maybe not done well in terms of polio vaccination that are applicable to COVID. So yeah, those are kind of the questions that I'm happy to hear from other parts of the world, what's going on with that.
Fantastic. Dr. Phadke, do you want to give a response to that to start with? Because India is a complex system, huge population, huge needs. And I think if you can, and I think it's probably one of the best programs in the world as well, despite all these challenges.
Yes. So yeah, I'm very happy and proud to say that we had the COVID management as well as the vaccination was handled very well in India. If you see the population and the number of healthcare workers are not as many as required for the population, but it was handled very well, and that is what we have to take forward now. So it has given a kind of confidence to us that we can do it. And as you mentioned about polio vaccine, I think that was asked before also, that polio gives herd immunity. So that is what we could utilize. And we, again, for polio eradication, we use multiple strategies and very new methods like pulse polio, surveillance, and many other. So maybe till now, what we have learned, we are following and giving vaccine to different age groups, all that. Maybe later we'll have to come out with more strategies to make it even a better vaccination program to cover everybody and see that maximum coverage. We cannot make it mandatory. I don't think in India it will be possible to have mandatory program. So we'll have to try convincing majority of the population to be vaccinated. That should be the approach. And then we should be able to have a COVID-free country.
Thank you. I mean, I recall as I was training in the south of India, Kerala, we used to have community outreach clinics in the rural parts of Kerala. And on the days when we did vaccinations, there would be queues of people. So people were really motivated, eager to have better, healthy life for their children. And I think that was a strong motivator, but that's taken years and years to develop.
Exactly. So it will take time. It's too early.
Take time. Say. Hendrikje, from your perspective, Hanif, please just jump in.
In Belgium, polio vaccination is mandatory. So, and it hasn't been a big problem the last years, but we have seen a decline in vaccination coverage among children in the recent years. And COVID didn't help with that. Since COVID, we see that it's declining further. It's not a big decline, but it is a decline, and we have to be aware of it. But we have, for the infants and the toddlers, we have the child and family centers, and they do a lot of influencing. They talk with the parents. They also provide the vaccination. So it's very easy, accessible for everybody, because everybody who gets an infant gets invited to go to the child and family services a few times. And when children go to school, we have the medical school supervision that takes care of the vaccinations now. So when people go to medical examination at school, the children get their vaccine, like the HPV vaccination is going via that service in Belgium. So that's a big help for us. But we see a decline in vaccination coverage the last years. And it's like Dr. Careaga said, it's because people say, yeah, we don't have polio anymore, so I don't have to vaccinate my child anymore.
Yeah. Hanif?
Just a quick comment, really. More as an observation, really. We also have the school nurse system within the UK, and largely, I'll be honest with you, vaccinations have just been routine in terms of conversations within the UK. There's never been a debate as much as there has been since the COVID about vaccinations and hesitancy and so forth, because in the school system and with regard to our the way the children's health services work from birth, vaccinations are just routine. You know, there's literally no conversation that happens. The last letter I ever remember, which the HPV rollout in terms of vaccinations for school-age children, particularly girls, early on, which is the first letter I ever received, which asked for consent on behalf of my child, you know, and then there was a slight debate where the conversation was really amongst parents rather than scientific professionals to say, what are you doing? What are you doing? You know, is everybody okay? You know, and largely most people said, I don't see any problem with this. I think it's a good thing. And then the children's health services within the schools just rolled out the vaccine, and that was done. And I think the biggest debate we've ever had has been around the COVID response. And I think you mentioned it, Katie, as well, but Varsha, both yourself, Hendrikje, and also Nav, who skipped this question process, I have to say. I'll have to have a word with him later. I think the issues around the homogeneity of the response, really, you know, treating everybody the same as if, you know, people's views and attitudes, their healthcare, their understanding is going to be the same nationally when the vaccine rollout started happening, has probably caused a lot of debate in itself. I also touched on, Katie, I think before you joined, the lack of trust perhaps from some of the, I loosely describe as immigrant communities within a country that had a colonial past, for example, you know, and there's some bit of trust between, you know, subordinate and dominant cultures and so forth within societies. And then I think it comes down to Nav's second point, around quality of the interaction, you know. So when you do have an interaction with the health system and professionals, that has to be absolutely right first time. You know, it is a long process. I agree completely with what Varsha has said, to get everybody vaccinated and have that communication conversation, but it has to start at the very beginning with the very right level of communication, so you can just build positively on that all the way, because there's just so much debate and social media, which is a great thing, but also so much misinformation out there as well. I think that is probably the biggest challenge for us. I think that's my view.
Brilliant. Thank you. I'm going to, I think we have some more questions from our audience, and we may have very little time, so we'll motor through that. So please, who's coordinating? Is this Barida?
Yes,
yeah, okay.
Jishnu would be asking the questions. It's okay.
Fantastic. Please, yeah.
Yeah, so I have a couple of questions that the audience has asked. I personally had a question, so I'd like to go ahead with that, and then we can ask the audience. So I wanted to ask Hendrikje ma'am that since you said that in Belgium you have been vaccinating children, particularly at a certain age limit. So that is not necessarily the case in India, as far as I know, or in the world otherwise. So do we see a possible harm or danger in the near future for children from the virus? And if so, why? I mean, everywhere in the world, there's not a single policy like for children to be vaccinated, like we have for elders. So we see a differentiation in policy. So is there a first question is there a possible harm or danger that we are seeing or predicting for the children in the near future from COVID? And secondly, if so, then how do we plan to take it ahead, like throughout?
Maybe I can tell why we started vaccinating the children in Belgium, because we saw a lot of quarantines in the schools in Belgium. Schools shut down because there were infections amongst the primary school pupils and the toddlers. We had some children who didn't go to school for like 2 months because it was quarantine after quarantine in the school. On the other hand, we also see that the risk at complications is a lot lower with children if they are vaccinated. So first we were raising the question, do we have to vaccinate all those children or just the high-risk children? But we decided to vaccinate all the children because the vaccine, it doesn't make you it makes you less infectious. It doesn't ensure that you are infectious, but it diminishes your infection rate. So that was also an important issue for us and an important criteria to go on with children vaccination. But the biggest concern was the welfare of the children, because children are a lot in isolation, in quarantine, and they can't go to their extracurricular activities anymore. So to put an end to that, we decided to vaccinate the children. We see that the vaccination rate with this small group of children, the 5 to 11 years old, is not that big. We started a campaign like 3 weeks ago, and I see now that in Flanders for the children we have a vaccination rate of 25% who got their first shot. In Leuven it's a bit higher. We have a vaccination rate at the moment, because we are still vaccinating them, of 35%, where all our other rates are 80% or more in the other age groups. So, and we bring that to the parents as following. We say it's not a necessary vaccination. It's not a mandatory vaccination. It's an advised vaccination. If you as parents decide my child doesn't need a vaccination, it's okay. We don't put pressure on it. So we see like a third. We hope that 50% of this target group will be vaccinated.
Brilliant. So the objective of the vaccination is to keep the schools, and students at school, and to reduce transmission in the community.
Yeah, and it's for the welfare of the children. Yeah,
absolutely.
Thank you so much, ma'am. Yeah. So the next question would be that I have is that how far do you think that the COVID-19 vaccine is going to be effective for the mutating virus?
I mean, the data we have, and it varies by the vaccine also. And we've seen, to summarize, we've seen good efficacy against serious illness, against hospitalizations with all vaccines. We've seen protection against reinfection to roughly a degree of around 70% with most vaccines, if you were to combine them. And we see with the Omicron variant, evaded vaccination. So many people have been reinfected. But again, if you look at the data around hospitalizations, ICU admissions, it's in the UK 0.02% of the vaccinated people have ended up in ICU. So the vaccines are hugely protective, especially the third dose. But again, as the virus mutates, the general trend has to be as the virus mutates, it tends to be a bit weaker, but it hopefully that continues. Any thoughts on that from the panel? Dr. Phadke?
Yeah, the efficacy is there, but it's very difficult to say because there may be many variants. So, and it may keep mutating later. So, it will be difficult to give answer to this question. But as you rightly said, this time we have seen those who are vaccinated, we have seen a good response, in the sense the hospitalization as well as ICU admissions were very less and they had a milder disease. So
yeah. Hanif, please go ahead.
Yes, so it's partly related to your question, Ishnu, but I think what I would say that is the efficacy of the vaccine and as the virus mutates going forward, it's how we handle the flu pandemic within the UK. So every year, we have a constant program that updates our vaccines responding to the variations within the flu. So treating the vaccine going forward treating the rollout of the vaccine from an endemic perspective of the disease going forward is, I think, going to be our kind of key strategy. I think I'm not sure whether that's the right answer, but it's what I would say in terms of why the uptake is being generally very high and therefore effective rather than the individual vaccine. It's the rollout nationally of it, is because we have a very sophisticated paternalism model. It's largely hidden from public view because we have something called the NHS, which as a construct is very trusted by the public, which is why we are able to roll out vaccines while people go out and undertake interactions with healthcare systems, because they're seen to be looked after from a society perspective by the NHS. So I think there's this kind of, the vaccine's efficacy, but also combined with how often we are able to do booster programs rolling out continuously, every 6 months, probably will have a big effect on that.
And just one quick point on that is that there are new vaccine technologies being looked at, including self-amplifying RNA vaccines, which require very small volume compared to current vaccines. So that gives you the potential to combine multiple vaccines. And again, the knowledge we have gained from the mRNA vaccine development is now being used in a number of different conditions, cancer, etc. So I think there's a lot of learning that's been locked in, but it doesn't seem. I think the undercurrent of the question is how long does immunity last? It probably doesn't last for very long. Katie, any thoughts on that? Any comments to the question? No, I just wondered if you wanted to add your thoughts to that, respond to the question.
I'm sorry, I forgot what the question was.
No, I think it was around vaccine efficacy, but that's all right. That's okay. Any further questions? Just no.
No, sir, that would be all. Thank you so much.
Brilliant. I just wanted to thank all the panel members for your time on a Saturday, and just a reflection on the journey of most of our audience who are doing the healthcare management program. The last 2 years and the learning from that is unprecedented. But in terms of learning of health systems response and how that could shape your thinking for your career, there couldn't be better opportunities to try and learn and lock in and transform so that we have a more sustainable, better prepared system. And one final point around NAVs, around climate and planetary health. Actually, we are starting programs even in the UK, which Hanif was involved in, we're, in a very systematic way, looking at population and planetary health together and finding the interactions of that. So that's probably the next big challenge, which should all harness together on. But that's enough me said. I'll pass on to any final comments from the panel and from the team at Somaiya.
I think it was a very, very enlightening kind of discussion. We covered so many different points related to vaccination, and we realized that vaccination is really very, very intriguing, whether you are talking about accessibility or distribution or equity or communication. At every level, all the countries, whether they are developing or developed, they are facing challenges. And maybe to a certain extent, we are moving ahead in the right direction. So that's what some kind of positive tone I can see from the panel members. And I'm very happy for all of you could join and really enlighten our students. Thank you so much.
Thank you so much for taking out your time for us. And we'll be moving ahead. Over to you, Barira.
Thank you, Vishnu. Thank you so much, panelists, and our moderator. Thank you so much for your time. We have met Dr. Katherine Careaga, ma'am, who is a critically applied medical anthropologist with extensive public health research and teaching experiences. She holds a Ph.D. in sociocultural epidemiology and a Master of Public Health with a concentration in culture behavioral dimensions of health from the University of Arizona, where she also worked as a border health researcher. She's currently teaching courses in cultural aspects of health, public health nutrition, and community health research at New Jersey City University. It is a pleasure to host you for the evening, ma'am. And would you please enlighten us with a few words?
Okay, I will try to keep it short. I did prepare a PowerPoint presentation, so I'm just opening that up. And then I'll share my screen.
Sure.
Let's see. Oh, the screen sharing is disabled.
Yes, ma'am, we'll enable. Anirudh?
Enabled now. Can you please check?
Yes, it is. Okay. Just. Oops. Zoom gets in the way, you know, those Zoom windows. Oh, as you can see, it's 6:26 in the morning here, and I'm joining you from New Jersey. And I'm not sure why. Let me go back. All right, so again, yeah, it's great to be here. I'm happy that I was able to hear a little bit about what's going on in other countries. And I'm certainly humbled and I'm really just coming to share a little bit about what we've been seeing here in New Jersey. And, you know, as I mentioned, my particular interest is vaccination of adolescents, of young people. That's what I have been researching on. And particularly as I'm situated at New Jersey City University, you know, some of the questions we've been asking is, you know, how do we ensure good COVID vaccination uptake within the institution among our students? And so I do want to talk very specifically about this kind of nested context, both of our institution, which is you know, within Jersey City, and talk a little bit about Jersey City. So throughout the pandemic, I've been engaged in kind of a project of trying to decolonize my teaching, and what I had been teaching and was teaching at the time, when we went through lockdown, was global health perspectives at Rutgers University. And so I became involved in decolonizing, or trying to decolonize, my global health teaching specifically. And there's been kind of a movement that's been parallel. And I think it's very relevant when we're talking about COVID-19, the determinants of COVID-19, and and vaccinations in particular, and how people relate to and trust. So I do, as a part of that decolonizing effort, do want to acknowledge the fact that New Jersey City University is on land that is a part of the ancient homeland and unceded traditional territory of the Lenape people. And at the same time, and please, I'm always open to learning, but the land of the Somaiya Vidvihar University stands on part of the ancient homeland and unceded traditional territory of the Warli and just other, I think, Adivasi peoples. And so I do want to pay respect to local Indigenous and Adivasi peoples, past, present, and future, and their continuing presence in the homeland and throughout the both Lenape and Warli diasporas. So this is really kind of representative of some things that I've been working on. But, I'm coming from a social sciences background, and, hopefully you guys have heard this quote by Rudolf Virchow: medicine is a social science and politics is nothing more than medicine on a grand scale. So I'm really coming to this conversation as, I'm not sure that I would label myself as an activist, but certainly, a person who is engaged with activism, global activism, and engaged social science perspectives. And that kind of colors my view of, what is public health. And, I think in the current panorama globally, right, what does this mean, not just for, I guess, government, if we think of public health as public policy and governmental policy, but also what does this mean in terms of, business, as health systems and healthcare in particular is either being privatized, or, in the case of the United States, already is quite privatized. And there's a very blurry line in our country between government and business, right? So we talk about neoliberalism, and how that's been really exported on the global scale. There's also, so I was happy to hear about planetary health, because that is a term that has been proposed and is being adopted, globally, and is seen as kind of being in accordance with this push to decolonize. There are different opinions about that. I have mixed feelings myself about planetary health, but I think it does indicate the need to kind of go beyond the current terminology that we have as far as public health and certainly global health, quote unquote, global health, and population health. And there are some limitations to the perspective of population health. So I think that as far as, actually, just to go back, when we talk about focusing on systems and reforming systems, I think that needs to go beyond, and I apologize because I do tend to be ambitious and idealistic, but I think that needs to go beyond kind of a narrow definition of health systems, even though seems like it's all that we can do in the United States to just reform our health system. But really looking at social systems. So if we're really taking a deep look at the social determinants of health, right, that goes beyond health policy, and we really need to be thinking about social policy and social justice, even beyond, the policy realm. So the topics of your conference have been focusing on accessibility, sustainability, and innovation. And I think my original reaction was like, oh, I can't really talk about innovation because as an anthropologist, I'm a little bit, conservative. And so I believe in learning from traditional peoples, traditional societies, as we term in anthropology, the other. And so I would propose that the innovation is to know our roots, to go back to and to listen and try and understand the other, I guess, point of view. And so, yeah, my main focus is on accessibility and, sustainability. And I think, again, when we talk about sustainability, it's not just programmatic sustainability. It's not just the sustainability of a vaccination campaign, but also, environmental sustainability, where I have worked for the American Museum of Natural History on what we call biocultural conservation, and really acknowledging not only the wisdoms of traditional knowledge for sustainability and for the, environmental, management, but really not only the need to be inclusive, but beyond that, to follow the lead of these kind of traditional paradigms and alternative, paradigms that are really, really rooted, again, in place and in the land. And so I guess I'm going to push us to go kind of one step further from what was mentioned in the last, or maybe I can go a little bit deeper into what was mentioned in the last panel, is that, yes, there are particularities of different populations, and those are very much rooted in not only, their particular context in the moment, but a whole trajectory of context, of place and changing place, and transnationalism. So people come to this country or other countries, right, as immigrants, already with a background and with knowledge that was informed by maybe other places where they were. And so I've definitely seen this as, being relevant in terms of some of both the challenges of COVID vaccination, but also the opportunities that can be built upon for sustainability and improving, healthcare accessibility in general, and vaccination accessing and uptake. I think that, well, it has been written, it's been observed, right, that a lot of times when we talk about culture, we almost always use it in health to talk about barriers, and we talk about cultural barriers of, it is a paternalistic approach, right, of vulnerable populations. And I really want to I want to highlight, I think, some of the facilitators that these particular populations experience or have, and even kind of the positive model that they provide for us, and the leadership that they can provide for us in, accessibility and planning, health planning. So a little bit about myself. I think you guys saw a a bio of me in the manual. But this is something, as I said, I've been working on decolonizing global health. And so this was actually a slide that I prepared for the Consortium of Universities for Global Health. So it's really focused on my global health teaching. But I did start out teaching in study abroad, and I've never taken a global health class, but the first class I taught was called Globalization and Health. And you can see how the name of the courses have it's morphed over the years. And so global health is big business in and of itself, particularly for our university system in the United States. And ended up teaching global health perspectives, which from the anthropologist in me was like, great, we can open it up to some other perspectives at Rutgers. And that's what I was teaching during the pandemic. And this led to, we had a very, very kind of, for me, frustrating kind of colonial, hegemonic textbook that I had to use at Rutgers. And so I started by, this was literally, I presented a discourse analysis or a textual analysis of the textbook, 2 chapters in the textbook, at the Society for Medical Anthropology conference in Havana, Cuba in March 2020. And the 2 days after I returned from Cuba to the US, the Havana airport shut down. And so we were in full lockdown, and we did not return to in-person classes. So before that, I had been teaching global health perspectives in a very old building at Rutgers University, which is a very colonial. So thinking about systems, right, and thinking about reforming systems, I think we need to look within ourselves. We need to look in our own, we need to look at the coloniality of our own institutions, right, and the place of our institutions. But Rutgers University is literally a colonial university, and the classroom that I had was it was in a very, very old building, and it was like a long rectangle, and the window at the end of the classroom overlooked the Johnson & Johnson campus, quote unquote campus, right? So we all know of Johnson & Johnson now because they are one of the vaccines, right, that was approved, and everybody was at first seeking out because it was only 1 dose, and now we need more boosters. So that's a little bit of the context of where I was teaching, what I was teaching. And then you see that I've been involved in these other activities around decolonizing and really sharing those. I would never ever say, I'm not even sure that you can, that it's possible to decolonize global health, but I would never say that I've reached decolonization, but it's something to work towards. And so this is specifically at NJCU. I have been teaching a lot at NJCU for many years, different courses, but one of the ones that I've been teaching kind of consistently for a while was understanding ethnic conflict and civil war. And so I'm really interested, again, in these particular vulnerable populations that are in situations of conflict. Or in the case of New Jersey, we do have refugee populations, and that influences I'd say their determinants, right? And their experience with government interactions. And so the research that I have been doing at NJCU has been on specifically adolescent vaccination practices within our student households, and doing some focus group research there. I recently was on a call, so they are speaking of engagement and activism. There is a push to organize around vaccine equity for the global health. Again, It's, the Global South is taking the lead on that, but I am involved with that. And I'm really coming from this perspective. This is really coming from community-based participatory research, but a movement from researching on populations, right, the minority populations, to really aiming to research with, and that is the case with NJCU, where the research has been a team effort involving my research students at NJCU. I know I'm running short on time, but I just want to, so this is all kind of background. Oops, sorry. No, it's not. I lost my mouse. Yes, so this is some of the, we actually authored an article on decolonizing, which has undergone some changes. It has not been published yet. But basically what we did in the process, so I had two indigenous co-authors from North America. One is from Menominee, where, so northern Wisconsin, Midwest of the US, where I worked as an epidemiologist at the Menominee Tribal Clinic. And the other co-author is Sautal from Chiapas, Mexico, but now lives in the United States in a neighboring state, Ohio. And so when we reviewed the literature on decolonizing global health, it basically highlighted three approaches. And one is, or on decolonizing, this was actually psychology, the critical perspective, right, and denaturalization, which was really a perspective that I was coming to, or coming from.
Professor Cathy, may I intervene? So I think some of the audience also have some questions. So if you could give some more time for question and answer and cover your work a little briefly, so that would be better. So otherwise we won't have any time for question and answer.
Okay. Yeah, so I mean, I can also open it up to questions, but I think the main thing is just to kind of emphasize the rootedness of place and collaboration, and in particular, my context is, we're right across from New York, so a lot of that, New York City. So a lot of what they were saying really resonated with us, as far as we have workplace mandates for vaccines, but especially in New York City, to get into places, you basically have to show proof of vaccination. We're kind of on the margins, but geographically of New York City, but we are one of the most diverse places in the country, and our institution is, goes between the most or the second most diverse institutions in the country as well. So we are dealing with a kind of mind-boggling, I think, array of diversity, where it's very hard to, and the people themselves are navigating a lot of interculturality, between different groups. So when I worked at the border, the main, other group was Native Americans and Hispanics. But here we just have, you can see it represented in both race and ethnicity, but also in the languages being spoken. So how do we adjust linguistically to this real diversity, linguistic diversity? And, people have ideas about the other and who is pro-vax and who isn't. And they make comments about the other based on those kind of judgments. And so certainly with India, we have it is the top immigrant nationality in the state of New Jersey. And so I think that it really points to the need for real transnational collaboration, not only cultural information, but I think also for structural, an understanding, right, even of the structures that our immigrant populations are coming from. So I just want to skip to, this is some of the data from the research that I did specifically within NJCU households, right? And so I think these were some common themes. And so certainly transportation has been a barrier for people. Originally, they set up drive-through COVID testing and drive-through COVID vaccination when we do have a pretty good, it's an urban transportation structure, although I'm very active also in migrant farm worker communities, rural communities where that is a real issue, just getting to places. But because we have a strong public transportation, a lot of people don't have cars, right? And there's not a lot of space for cars. So the drive-through was a real problem. People are definitely suspicious of government and possibly industry as well. And we have a lot of first generation students. So I hesitate again to limit it to a lack of critical health literacy or limit to health literacy skills, but just, there's this trend of, oh, I did my own research, this kind of neoliberal, like individualistic, I did my own research, which I'm like, wait, coming from research, that's not how research works, right? It's usually a team endeavor. And so I think we're also, it's really important, again, in thinking of systems, to think about our educational system. And is our educational system, not only giving degrees and checking off a box of, oh, I have a bachelor's degree, I have a master's degree, but are we building these critical literacy skills and these research skills there? But there's a lot of facilitators and, a lot of the students and like our larger community, they're coming from this experience of immigration where they were required, there were mandates, there were immunization mandates for people to come here to the United States. So they're kind of more accustomed or more conscious, I think, more aware of the mandates than our general population, our US population. There is an immigration filter. So, particular our Asian immigrants tend to be of a higher educational status, less poverty in our Asian population. And, a lot of times they are coming from kind of the colonial elite class. There's a lot of times a personal history with other much more public healthcare delivery systems. And people somewhat expect that in a way. And I've seen that especially with Latin American immigrants, where Paterson, which is close to us, Paterson, New Jersey, was actually immigrated, or they were actually immunizing anyone who showed up. They weren't asking for immigration status. And I have lived in Mexico and I own a house in Mexico. And I know people, Mexicans, that have come to the United States like just to get vaccinated. And so certainly there's a demand because it's harder to get in other countries in the global South. And so sometimes the people here, like they see that, they know that. So sometimes they actually are seeking out, immunization more than other, non-immigrant people. Okay. And the
Professor Kathy, my apologies, but we'll have to cut short this. And really, very, very interesting take and so many interesting insights you have been sharing with us, especially regarding the immigrant and colonial populations and the difficulty of vaccinations. Thank you so much. But really, my apology. We'll have to really, can we just, we have to move the program a little bit because we have teams have just joined us who have participated in the morning events. And so there are guest of honors who have also joined us to announce results. We have had a very interesting day of deliberations and research paper presentations. So with your permission, can we move forward?
Yes, yeah, go ahead. Did you want to open it up for questions, or is there not time?
I think now it will be a little difficult. What we can do is we can send the questions via mail to you if that's okay with you, if you're okay about it. So I will request my student POCs to compile the questions and probably mail it.
Okay.
Okay. Thank you so much. Thank you, ma'am.
Yeah. Thank you.
Thank you. And just to add on to Poonam, I think the kind of diversity and challenges of diversity and inclusion you mentioned in your city and USA, similar kind of challenges we are also facing. And so I can see a lot of similarities in what you were talking about, and I could relate it to Indian economy as well. Thank you very much.
Yeah, yeah, you're welcome. Yeah, especially I think Mumbai.
Yes.
Right. Mumbai is very globalized.
Well, thank you so much. A heartfelt gratitude to you to choose to connect with us at 6:26 a.m. in the morning. Thank you so much, ma'am. As the event draws to its close, it is now time to announce a winner for this year's case study competition. I would like to request Dr. Deepali Kadam, ma'am, Associate Professor in the Department of Community Medicine at KJ Somaiya Medical College and Research Center, to do the honors, please.
Yeah, thank you. Good evening, everyone. First of all, I would like to thank Dr. Prema, madam, for encouraging me to be a part of the organizing committee member. And I thank our Dean, Dr. Varsha Phadke, madam, for the same, for giving an opportunity to be a part of this conference. The winners, okay, for which everyone is waiting for this particular moment. So I announce the runner-up team is Team Frenzies, okay, Dr. Manish Kumar and Dr. Parnika. And
Ma'am, hold on, please. Ma'am,
yes.
will presentation. Just for a second. Yeah, Anirudh, go ahead, please.
Yeah, I will.
Sorry, ma'am, please go ahead.
May we
Yes.
have a round of applause for the runners-up team?
Yes, yes. Congratulations, Team Frenzies.
Thank you so much, ma'am.
So much, ma'am. Thank you.
Yes. And now the winning team. Any guesses? We have the team aspirers. So congratulations, Jennifer and Gayatri Darla from KJ Somaiya Institute of Management. Yeah. And
Thank you so much, ma'am.
yes, and Dr. Manish Kumar and Dr. Parnika are from Tata Institute of Social Sciences.
Yes,
So
ma'am.
congratulations, winners. Yeah,
Thank you so much, ma'am.
Yeah.
Thank you, ma'am.
Thank you so much, ma'am. Heartiest congratulations to Team Aspirers. It was a pleasure to have such wonderful teams participate in Somaiya 2022.
We are now in the last section of the day. We had really illuminating and didactic presentations today. Juries have submitted their judgment. We appreciate the contribution of all participants to the conference today. And now we shall proceed with the prize distribution. I cordially invite Dr. Mangesh Pednekar sir, Director at Helis Sexeria Institute for Public Health, for announcing the best award-winning papers.
Yeah, thank you so much for the invitation. And I agree with you. In this second international conference, the abstract presented were excellent, and choosing two abstracts from such a wonderful presentation, it was a very task, and that task has done by the committee, and they have done a wonderful job. So I am very happy and delighted to first announce the runner-up paper. The runner-up paper is Determinants of Digital Health Information Search Behavior by Surya Niragatti, Dr. Ranjit Kumar Dehru, and Nishala Sripati of University of Hyderabad. Heartiest congratulations to the team.
Thank you, sir. Thanks a lot.
Okay, and now I am very, very happy to announce the winner paper in the second international conference. It is on mental health in higher education, the use of open spaces by Dr. Aparna Pandey, Dr. Anjali Chopra, and Dr. Shailaja Karve of KJ Somaiya Institute of Management. Congratulations to the authors.
Thank you so much. Thank you so much.
Thank you so much, and all the best.
Anjali ma'am, you wanted to say something?
Yeah, I said thank you so much.
Yeah, man. Thank you. Congratulations.
Thank you.
Over to you, Barira.
Yeah, thank you. Congratulations to the authors for giving their best and winning the most coveted title of the day. With this, we would like to express my heartfelt gratitude towards all the esteemed panelists, juries, and participating teams for taking out all their precious time for us.
I would now request Jaya Matthew ma'am, convener of our conference, to address us with a vote of thanks.
Thank you, Jishnu. Good evening, everyone. I feel honored and privileged for having this opportunity to propose the vote of thanks on this special day. First of all, on behalf of Somaiya Institute of Management and MBA Healthcare Management, I would like to convey my hearty thanks to the chief guest of today's valedictory function, Dr. Katherine Careaga. Thank you, Dr. Katherine. Now, we would like to thank the moderator and the panelists of today's panel discussion, Dr. Pramod Prabhakaran, Dr. Varsha Phadke, Ms. Hendrikje Huysmans, Mr. Nav Chana, and Mr. Hanif Wazir. Dear panel members, thank you for this wonderful and active engagement. This is very well done. And dear Dr. Pramod, thank you so much for helping us plan this and make it a success. Now, we would like to record our heartfelt thanks to our knowledge partners, Healy Saxaria Institute for Public Health, Somaiya Medical College, Hospital and Research Center, and New Jersey City University for their continuous support and guidance for making this conference a grand one. And we thank AMDISA, the Association of Management Development Institutions in South Asia, to co-brand our conference through the scheme of AMDISA supported programs. We would like to mention our deep sense of appreciation for Dr. Mangesh Espednikar and Dr. Deepali Kadam to accept our request to announce the Best Paper Award and Samavesh case study winners. Special mention to our Honorable Chancellor, Sri Samir Somaiya, for joining us at the Second International Healthcare Management Conference. We would also like to thank our director, Professor Dr. Monica Khanna, being the catalyst that inspired us to do our best and stand as a pillar of power. We would like to acknowledge the efforts put in by Dr. Satyendra Upadhyay, Director, International Relations, to get us connected with the international universities and other international organizations. On behalf of the Somaiya Institute of Management and MBA Healthcare Management, I would like to convey my regards and hearty thanks to all the honorable track chairs, reviewers, paper presenters, and delegates who blessed us with their presence. We also want to thank the people who worked behind the scenes to execute this event. Thank you, Mr. Arvind and PR team, Mr. Subhash, Freeman, and IT team for all your support. Our sincere gratitude goes out to Mrs. Shilpa, Mrs. Meenal, Mrs. Shailaja for their administrative support. We would also like to mention the commitment and the involvement put in by Professor Dr. Prema Basargekar, the convener of the conference. And we have been fortunate to be supported by a team of very sincere students of MBA Healthcare Management. Thank you to student conveners, Barira, Sejal, and Jishnu, and the entire organizing team, and to the all the students of MBA Healthcare Management. Thank you. Over to Barira and Jishnu.
Thank you so much, ma'am. Thank you to you too. With this, we have come to the close of the event. We are thankful again to all the members of IT team of KJ Somaiya Institute of Management, the Second National Healthcare Conference conveners and co-conveners, the teachers and students. Without their help, it would have not been possible to make this event a grand success. Thank you and goodbye. I would like to request the organizing team to please stay back while everyone else is leaving.